Neurology quiz number 81. Discuss the clinical features, management, and sequelae of febrile seizures. Febrile seizures were defined by the ILAE in 1993 as a seizure occurring in childhood after age 1 month associated with a febrile illness with temperature more than 38 degrees Celsius or 100.4 degrees Fahrenheit, not caused by an infection of the CNS, without previous history of neonatal or unprovoked seizures, and not meeting criteria for other acute symptomatic seizures. Incidence of febrile seizures is 2 to 5% in the white population and 8 to 10% in the Asian population. Febrile seizures are most common between the age of 6 months to 5 years, but the range varies from 1 month to 8 years in the literature. 90% of children have their first febrile seizure before age 3 years, and peak age is 18 to 24 months. A positive family history of febrile seizures or epilepsy increases the risk of febrile seizures and has been described in 25 to 40% of patients. Genetic epilepsy with febrile seizures plus is a familial syndrome with autosomal dominant or complex inheritance patterns. The most common epilepsy phenotypes are febrile seizures or febrile seizures plus. The latter refers to patients with febrile and afebrile generalized tonic-clonic seizures, or in whom febrile seizures continue beyond the usual age limit of 6 years. Other epilepsy phenotypes may also be seen, including focal epilepsy, myoclonic and atonic epilepsy, and Dravet syndrome represents the most severe end of the GEFS plus phenotype. The condition is most commonly due to mutations in the sodium channel gene. Clinical features. The majority of children with febrile seizures have normal development. There is no sex predilection. Most febrile seizures occur at or around the onset of fever. The fever is most commonly due to self-limiting viral infections of the ear, nose, throat, or respiratory or GI systems. In the FEBSTAT study, febrile status epilepticus was associated with human herpes virus 6 infection, and overall HHV infections were noted in 30% of patients with febrile status epilepticus. Other pathophysiologic factors have included peak temperature during the illness, rate of rise of fever, vaccinations, and low birth weight. However, their role is not established. Febrile seizures are classified into two types, simple and complex. Simple febrile seizures are single, generalized convulsions lasting less than 15 minutes. Complex febrile seizures are focal seizures, occur as clusters during the same 24-hour period, have a duration of more than 15 minutes. Approximately 20 to 35% of febrile seizures are complex. Investigations. It is important to find and treat the cause of fever. CNS infection and metabolic toxic causes are especially important to exclude. Lumbar puncture is indicated, number 1, if history and examination suggests possibility of meningitis or intracranial infection, such as meningeal signs. It is an option in infants 6 to 12 months of age when the child is considered deficient in H. flu type B or strep pneumonia immunization, or if the immunization status cannot be determined. It is also an option when the child has been pre-treated with antibiotics, as such treatment can mask the signs and symptoms of meningitis. Neuroimaging such as CT or MRI is usually not indicated unless there is clinical suspicion for an acute neurological condition or history of focal hemiconvulsion suggests an underlying structural cause. EEG is of limited utility. 30 to 40% of patients may show transient abnormalities after the seizure. However, it is not considered useful for routine diagnosis. Management. Most patients with febrile seizures do not require hospitalization or intensive medical intervention. If the child is seizing when first seen, the abortive treatment of a prolonged febrile seizure or febrile status epilepticus does not differ from the usual treatment of such seizures. Caution should be exercised in using sodium channel blockers such as fosphenytoin in patients with a known diagnosis of sodium channelopathies, as they can worsen seizures. Vital and neurologic signs are monitored following the febrile seizure. Fever reduction with antipyretics is recommended, although it is not clear if these impact the duration of the febrile seizure or the chance of recurrence. A rapid and full post-seizure recovery can establish the self-limiting nature of febrile seizures and obviate the need for extensive testing. Rectal diazepam can be used to abort an ongoing seizure at home. Caregivers should be educated in the technique and timing for administering the drug, as well as close monitoring after its use. Intranasal midazolam can be used as an alternative. Use of daily anti-seizure medications is not justified. Phenobarbital and valproate have been reported to reduce the occurrence of febrile seizures, but may not decrease the risk of developing epilepsy. Such treatment may be utilized in a small percentage of children with complex febrile seizures and febrile status epilepticus, and with multiple risk factors that predict a high risk of epilepsy. However, there are no well-defined guidelines for initiation of daily anti-seizure medication. Risk of febrile seizure recurrence. 30% of children have a recurrence following the first febrile seizure. A third febrile seizure is reported in about half the patients who had a second seizure. Thus, only about 15% will have a third seizure. More than 3 febrile seizures are rare and are seen in less than 5%. Risk factors for febrile seizure recurrence include the following: age at the time of the first febrile seizure. Younger the age, higher the recurrence. Age less than 1 year is associated with high risk of recurrence. Family history of febrile seizures in a first degree relative. Relatively low grade fever during the febrile seizure, that is less than 40 degrees Celsius. Short fever duration. Seizure occurred within 1 hour of fever onset. Recurrence does not seem to be influenced by the duration of the initial febrile seizure or whether it is simple or complex. Risk of epilepsy after febrile seizures. Risk of developing unprovoked seizures after a febrile seizure is 2 to 5%, which is 2 to 3 times the risk of epilepsy in the general population. Risk factors for development of epilepsy are as follows: complex febrile seizure, prolonged seizures of febrile status epilepticus. These can be associated with hippocampal injury and mesial sclerosis. Febrile status epilepticus occurs in less than 10% of children during the first febrile seizure. Developmental delay or abnormal neurological examination prior to the first febrile seizure. Family history of epilepsy in a first degree relative. Recurrent febrile seizures and late age of febrile seizure onset, that is more than 3 years, may also be risk factors for epilepsy according to some studies. Of patients with a simple febrile seizure, only 1 to 2% develop epilepsy, which is only a slightly higher risk than the general population.